Okay, can people hear me? Hopefully it's nice and clear. It's very nice to be here with you. It's the middle of the night here, of course, and it's already Friday the 13th. So let's explain the mishap in that way. Okay, so I want to take you through some of the work we've been doing in Australia and the UK and various other countries. And part of this developed out of our interest in really understanding the perspectives of everyone. And this includes people from Aboriginal backgrounds or people with who are perhaps marginalised, people who usually don't engage in healthcare for a whole wide range of reasons. So we're very interested in including all kinds of groups and consultations to all kinds of parties. So we're interested in those people who are usually cannot be making decisions about their health. So on the left side of this graph, perhaps people who are comatose. They can't make decisions because they're so poorly. At the other end, you might have health and fitness fanatics. And these people, it doesn't matter what you do to them, they'll do really well. What you do with people at this end of the graph and this end of the graph is different because they have different needs and different capabilities. So one size doesn't fit all. So that's a principle to start with. And in developing interventions or programs to improve public health, improve health services, there is a technology out there. This is intervention mapping, and it's widely available, but many health services improvement folk and public health people don't formally study or actually understand how to develop interventions that could be implemented in full and are fit for purpose. But there is a technology out there. And it starts with a needs assessment. This needs assessment, we think, needs to include the voice of patients or people, consumers, we tend to call them in Australia, but also the needs assessment needs to include the needs of the system. That's practitioners, planners, managers and policymakers and other parties. We need their voice as well. When you get this voice or the needs assessment, you have a much better chance of understanding what on earth you need to do to develop something that might be fit for purpose and implementable. And this is one of the foundations of the Ophelia approach. But of course, if you get this first step wrong, this needs assessment, everything else will be wrong, won't it? Or if it's not well informed, you're in much greater chance of developing something that may not be implementable or fit for purpose. So, how can we find out about patients? If we want to develop an intervention to improve the patient experience broadly, what do we need to find out? Well, methods of actually getting information about patients, well, you can simply ask them, you can do interviews, you can give them a questionnaire, you can observe them, you can do group interviews or focus groups, and you can put them on committees, all the sorts of things that I'm sure almost all of you have been involved in. You could also ask the people around them, their family, the carers, the healthcare professionals. You get very rich information that way. Or you simply could observe what they say and do and what happens to them. But there in red, how can this be done with accuracy, efficiency and integrity? That's been our inquiry. And there's various problems and strengths with current approaches to getting the patient perspective. Now, who do you actually speak to? Which patients do you select? What questions should be asked? And what about the researcher bias coming in with their own particular theories, their own points of view? They're all ways of really potentially producing something that's not fit for purpose and doesn't really reach into the hearts and minds of ordinary people. So this is where health literacy comes in. Our interest in health literacy stems from a lot of work in chronic disease self-management, or the expert patients program, which I've been evaluating for really over 10 years in many settings. I was able to see that perhaps in many settings, expert patient programs were one size fit all, and so many people with low capability weren't really engaging in the services that were provided. So health literacy is the characteristics of the person and the things and supports they need. such as skills, knowledge, motivation, beliefs, confidence, resources and supports to access, understand, appraise and use information and services to make decisions about their health and the health of their family and community. So it's quite wide-ranging. But then alongside this is this concept of health literacy responsiveness, and it's the way in which services make information, resources, supports and environments available and accessible to people with varying health literacy strengths and limitations. So health literacy is not just like the patient's problem, but it's also the health systems or services problem or opportunity, you might say, to build an equitable and safe and effective system. And I guess most of you will have seen the Scottish document around here, and the title of their policy around health literacy is Making It Easy. A bit of a hint there that health literacy responsiveness is important. So our view is that irrespective of a person's capabilities, we need to make services suit their needs as much as possible, humanly possible. But what really is health literacy? I'm a bit of a measurement guy. I've done a few questionnaires, including many measures in musculoskeletal and self-management, and got really annoyed with the health literacy measures out there and needed to find out what it was. And this is a quote which really reflects our approach. And this is from Søren Kierkegaard, who's a philosopher from Denmark. So if one is to truly succeed in leading a person to a specific place, one must first and foremost take care to find him where he is and begin there. I hope that resonates with a lot of people. And that's our starting point for our research. It's like a grounded approach. We don't come in with a particular theory. We come in to listen very carefully to a wide range of consumers and then develop our work. So we have a structured process to do that, and it's called concept mapping. And it starts with a brainstorming session. And this statement here, thinking about your experiences and trying to look after your health or the health of your family, what abilities does a person need to have to be able to get and use all the information they need? It's a very general statement. And this embodies the WHO definition of health literacy. If I say health literacy, that's just jargon and no one really knows what that means. So we have to explain it. So in response to this, a wide range of consumers came up with these 9 elements. And I'll just read them through quickly. This is being recorded and you'll be able to catch up with this later, and we'll be able to send it around. But these are the 9 things that ordinary consumers and ordinary practitioners and ordinary policymakers kind of come up with using this grounded approach. So health literacy is about feeling understood and supported by healthcare providers. It's about having information to manage your health. Number 3, actively managing your health. Number 4, social support for health. Number 5, appraisal of health information. Number 6, ability to actively engage with healthcare providers. 7, navigating the healthcare system. And 8, ability to find good health information. And 9, understanding health information well enough to know what to do. So they're all written in a way, hopefully it just reflects ordinary experiences of people. And that's what we did find, that they are reflecting ordinary people, because these concepts or these terms came from the lived experience of ordinary people in the community using this grounded concept mapping approach. So in a way, what we have here is a health literacy needs diagnostic. It reflects patients' health literacy needs, but also the organisational health literacy responsiveness that's needed. You can imagine, by looking at these dimensions, it does pick up on patient characteristics, but captures their lived experience of trying to engage with healthcare providers. So here's some quotes from various sectors. From primary care, our group said, "Richard, these are things that doctors hate most about their patients." Good grief. It does indicate we're onto something which is important. This one here, this describes the heart sink patient. "These look like ordinary questions," said a frontline practitioner, which is one of the greatest compliments I've had in my career, that a frontline practitioner who has no time for researchers like me says, "Oh, these are ordinary questions reflecting ordinary people's lives." Excellent, we thought. So here's perhaps a scorecard for a patient. You can see here, these are the 9 dimensions down here of the questionnaire, the health literacy questionnaire. This is a little solid person's shape is perhaps the population norm, and we can see differences from a particular patient score. So here we have perhaps, oh, Mrs. Jones, you seem to know your health, know your way around health services. This is terrific. So she's stronger than perhaps a population norm. But an example, the next example here, oh, Mrs. Jones, you seem to have a lot of trouble being motivated. Why is this? So different people have very different profiles. Everyone has strengths and weaknesses. We need to find these strengths and build on those, and find these perhaps weaknesses and help compensate those, or build systems around people or strengthen people in these particular areas. These concepts can also relate to the averages of the health services. I did this work for Wales. Swansea and Cardiff had perhaps different responses. Why is that? And we can make judgments about health services or particular organisations, or even the patient population groups across different NGOs or health services. And this is a complicated graph. I apologise to you, but this measurement health literacy concept has been applied in population health survey. So the blue dots is the population average, and we have different groups with different chronic conditions. I guess the main message here is people with mental health really do find many aspects of health literacy far more difficult. But the good news here, people with cancer, the orange, do seem to be getting very good information through their cancer journey, and at least the same as the population. So now I would explain, with that background, the Ophelia approach, funded by the Victorian government and also by Deakin University and Monash University here in Australia. So we have some very clear principles for how we want to operate. We're trying to build a system by which you can develop interventions, implement them for them to be fit for purpose, where an organisation can do it for themselves, for their own client population, their patient population. It's not about a university or a research group coming doing it to someone. It's actually building the skills and having the tools available for organisations to get on with doing improvement in a profoundly, hopefully, equitable way. So very quickly, this Ophelia principles focuses, 1, on focusing on improving health and well-being outcomes. Number 2, to respond to locally identified health literacy needs. 3, focusing on increasing equity in health outcomes and access to services for people with varying health literacy needs. 4, prioritise local wisdom, culture and systems. I'm going to come back to this a fair bit. Number 5, engage all relevant stakeholders in the co-creation and implementation of solutions. Number 6, focus on improvements at and across all levels of the health system. 7, focus on achieving sustained improvements through changes in environments, practice, culture and policy. And number 8, to respond to the variable and changing health literacy needs of individuals and communities. So all these principles come from our last 15 years of research and developing interventions, implementing them in very different settings in different parts of the world. And we see these are the foundations for us to do, hopefully, have packages of implementable work. There's details here about the background to this, a bit of a hard read, but those who are interested can follow it up in this open access journal. So this is the Ophelia process. It starts with local stakeholders, identifying local priorities. Then we administer this health literacy questionnaire. It's the local needs assessment. Then we have a process to uncover local wisdom or practice excellence. I'll go through that shortly. This is the really rich part of the magic of this approach, we think. Then it's about sharing local wisdom, co-develop frameworks, and develop a community practice and rapid sharing. In the implementation, it's about local pride, test, learn, evaluate, feedback, and compare. And what we're doing ultimately is building a knowledge hub, lots of narratives, practical terms, and context, and making sure things are context relevant. So that's in a nutshell. There's more things I need to explain. So we see health literacy as a problem-solving tool mostly to assess and meet the needs of those who do not access or benefit from existing services and approaches as much as others. So there's inequalities there. It's deeply linked to the concept of equity and the concept that not everyone has the same needs, and that effective approaches are not the same for everyone, a constant theme in our work. So, as I mentioned before, if you're going to develop an intervention and you get this needs assessment wrong, then everything else might be wrong. So this health literacy tool ends up being very clearly our needs assessment to find out the micro mechanisms across different groups of people about what enables them or disables them from engaging. But how can I find this local wisdom? Well, what is local wisdom? Well, many of us have been to a doctor or have got a manager who's amazing. They really seem to understand us really well. A patient comes in, sits down, they're blue with pink spots. Gradually, the clinician, when they sit down, they have blue and pink spots, and that person leaves that consultation really feeling they're understood. Some clinicians and managers have just great empathy, great insight into the human condition. These people have enormous things to offer, and they have potentially thousands of strategies that are or can be used by health and social care workers in direct contact with patients to optimise engagement and outcomes. They're there all the time. Alongside that, there's potentially thousands of strategies that are or can be used by patients that optimise their engagement and outcomes. There's some people who just do great work in their own lives, with their illness work, to get by, despite coming from very challenging backgrounds or having very challenging conditions. They do magic in their own way. They have their own local wisdom. So these strategies in many ways will impact on one or more of these health literacy domains, these fundamentals of a person's ability to understand, access, engage with health information, health services. So why don't we use this, get people to fill in this health literacy questionnaire, then we can help discover what local wisdom is out there. But if I go to a health services or NGO and say, hey, here's your average scores on these 9 dimensions health literacy questionnaire, this is rather boring, mundane, quite meaningless, and it's in no way useful. But there's a technique called cluster analysis. Let's just try to do an analysis, a multivariate analysis, and get those people different who are scoring the same on the questionnaire to be grouped together into same groups. You can imagine going to, let's say, a supermarket and looking at the shopping trolleys. Different subgroups of society will have different ingredients in their shopping trolleys. Some will have lots of vegetarian items, some are really healthy, some come from Southeast Asian spices might be their thing, so you can see their preps from a different country. You can see different patterns. That's the sort of thing that this cluster analysis does, and it kind of looks like this. It's a bit complicated, lots of numbers, but it's a bit of a, up here we have profiles of people commonly with lots of strengths in their health literacy, and down below people have different combinations of lack of strength or weaknesses in their capabilities across the 9 dimensions of health literacy. This helps us find different subgroups in society to think about. Out of this, we seek to develop patient stories. And I see in the audience we've got Sue Roberts. So this is some work we did with her in Newcastle. So this is a vignette, a story, which came from some work we did there. So Simon's a 51-year-old man who works as a painter and decorator for a large firm. He's finding the work increasingly difficult as he gets older, mostly because of his back pain he's had for years. He's a heavy drinker and smoker and has noticed that he's starting to get out of puff when he climbs ladders. He feels quite depressed about his worsening health, but just sees it as being part of getting older. His father died of heart disease at age 60, so Simon half expects the same thing will happen to him. He's aware that he should take steps to stop smoking and drinking, but doesn't know where to go for help, and he tried to cut down last year. All his mates just laughed at him. He doesn't really trust doctors anyway, and he's been telling them about his back pain for years, but they haven't done anything about it. So this is one patient story. So if we think about this diagram here, we've just picked up one patient story. So this technique here gets us a nice profile of people across our community who we seek to serve, develop new interventions for. So all these stories link to the hard data we collect from people in the community. And then we ask people in workshops, whether it's a patient group, 5 to 10 or 15 people in a room who are patients, or separately, usually clinicians, we'll ask this question: what can people like this do to have the best chance of getting and maintaining good health? So we have a lovely discussion about this, and people in the community see these stories, these vignettes from these data, and they say, yeah, I know people like that. I know people like that. We ask them, how do we help people like that? And ordinary people in the community come up with a huge range of ideas. We do also ask, if there's lots of Simons in our community with a health literacy profile like this, what can our community do to give them the best chance of maintaining and getting good help? So then we look at the collective idea. How can we actually all work together as a community? So here...
Richard, I'm really sorry, it's Sally Brearley, I'm chairing the conference here in London. I'm really sorry to interrupt you, but because we couldn't get to you when we wanted to, we're going to have to wrap this up in the next couple of minutes.
Sure.
It's fascinating what you're saying, and I'm really, really sorry to have to cut you short. But is there any way you can sort of round this up for us in a couple of minutes, and then we'll get in touch with you later with questions?
Absolutely.
Thank you. Thanks very much.
So if you think how we're working right across this here, so we're getting great detailed conversations and hearing the local wisdom from people, which is based on evidence, based on truly the profile of the community. And we package this into a system. So let's say we uncover for the first dimension all these things about building trust. This is to feel understood and supported by healthcare providers. Building trust is really important. Provide patient-centered care, coordinate care. So we're from ordinary people in the community and great practitioners, we're getting the full range of ways in which we respond to different people in the community. So across all the dimensions, we can build a whole system of what is best practice that's currently in our community, which can really work, and we know is implementable because these ideas come from the community. At the same time, we're building what do we need to do to support practitioners to do their best work. And what do we do then also at the organisational level to really optimise and improve at the system level. And then at the interagency level, we're doing the same thing. So we're actually building a whole of system improvement process. So to wrap up, this sort of work is happening in many, many settings. We're able to work with people in Oldham, the Newcastle group of doing excellent new work. We're working with the Welsh Government, the Scottish Government, and in various developing countries as well. So what we're aiming to do here is engage in a very deep and profound way with people in the community such that their voice can be heard. Their voice can be heard. So the Health Literacy Questionnaire is the voice, the hearts and minds of ordinary people. Collectively, we can get ordinary people to fill in this questionnaire with support, of course. If they can't read, we interview them. We go to great lengths to get their voice. But when we do this cluster analysis, the voice of the most disempowered people becomes just as loud as the empowered, as the people of different combinations, resources. So all the voices get put on the table. Then we tap into the local wisdom from great practitioners and great resourceful ordinary consumers, and collectively we can build what do we need to do at the individual person level to build their capacity, to enable them to have a chance. What do we need to do to support practitioners to do their work? How can we reorganise health services such at the end of this we have a whole systems approach to improve equity and health outcomes? Thank you.
Thank you very much.
You're welcome. Good day.
Good day.